I'm Dr. Nick LeRoy, author of Painting a Target on HPV. If you're watching this video, you likely have HPV, or you have an abnormal pap, or maybe you've had a long history of dealing with HPV and you're getting frustrated and you don't know what to do about it. The purpose of this video is to help you decide what to do. And to decide what to do, you really need to have an understanding of what HPV is, how you get it, what it does, what to do about it, what an abnormal pap is, the difference between an abnormal pap, and findings on pathology. If you really don't have a firm grasp of the terminology involved and what it is, you're going to be at the mercy of what may be good information or may be bad information. What you don't want to do is have regrets. You don't want to find yourself years from now where you've had multiple LEEP procedures done, you're not clearing HPV. In the past 25 years of treating HPV and HPV-related disorders, I've seen countless women who've had years of problems where they've had multiple LEEPs and maybe 10 years later they're still struggling with HPV. So you don't want to have that happen. There's a way to properly treat HPV and ways to not treat HPV. So first off, what is HPV? HPV is the human papillomavirus. There are many strains of HPV. Some are low risk and some are high risk. High risk strains are associated with cancer. There are about 15 high risk strains that we currently test for. Low risk strains are associated with warts. All warts are caused by HPV. If they're on your feet, we call them plantar's warts. They could be on your hands, they could be on your genitals, they could be on your face. All of that is HPV related. However, that's all caused by low-risk strains of HPV. There's also high-risk strains of HPV, and the high-risk strains are really the strains that we're concerned about. In fact, if your doctor told you that you have HPV, what your doctor's talking about almost always is high-risk HPV. It's the high-risk HPV that we're concerned about because unlike the low-risk strains, the high-risk strains are more likely to cause problems. They're more likely to cause cancer. So how do you get HPV? HPV is thought of as being sexually transmitted, and it is. However, there's other ways that a person can obtain HPV. In fact, HPV can live on the surfaces of objects for up to about a week. So at the end of the day, we all end up being exposed to HPV. It's just a fact of life. In fact, at any given time, any person walking around, there's about a 50-50 chance that he or she has a current HPV infection. So at the end of the day, we all end up being exposed to HPV in some form or another. You could go in a shower area and have your feet be exposed to HPV. Potentially you could shake somebody's hand or maybe grab a doorknob or something and you may be exposed to HPV. Now, I'm not telling you that to freak out about it. I'm telling you that we all end up getting exposed to it. But exposure doesn't necessarily mean you are going to get it. And if you get it, it doesn't necessarily mean that you're going to have a problem with it. So, the big question, can you get rid of HPV? Absolutely, you can get rid of HPV. In fact, there's studies that look at clearance rates. You know, I've been amazed how many women that I see over the past 20-25 years that are confused about this. And there's conflicting information on the internet. Even gynecologists themselves will often contradict themselves. So this is usually how the scenario works. You go to the doctor, you think everything's okay, you do a pap, it's your annual exam, you do a pap, you get a phone call, doctor says, well, you showed up HPV positive, but your pap is normal. And then the conversation usually ensues like this. You'll ask, well, is there anything I should do or is there anything I need to do about the HPV? Your doctor will almost always say, don't worry about it, it'll go away by itself, you don't need to do anything, we'll recheck it in another year, and the chances are it'll go away by itself. So initially your doctor's saying, don't worry about it, it'll go away by itself. If you're one of the unfortunate ones, however, and it doesn't go away, and it gets worse, and a year later or 2 years later it suddenly becomes moderate or severe dysplasia, your doctor is going to do a 180-degree about face and say, oh, we need to do surgery right away, otherwise this could become cancer, and they'll start talking hysterectomy. The fact of the matter is there are studies on clearance rates. We know that you can clear the virus. You can't have it both ways. You can't have it one moment that you can get rid of it, and then under another circumstance, well, you can never get rid of it. The fact is there's studies showing you can get rid of it. When we look at clearance rates on surgery, for example, if you have a LEAP procedure, there's about a 60 to 65% chance that you'll go negative on HPV. Those are called clearance rates. We also know that most women will end up clearing the virus, usually within about a year or two, often without necessarily doing anything. Part of the reason we know that you can get rid of it is because there's studies that have identified who clears it and what happens. And the one study, which I cite this in my book, they looked at women who had HPV-16. Women who clear HPV-16 have a targeted immune response against HPV-16. And the virus clears, it goes away, and it's gone. And in the same study that looked at women with HPV-16 who didn't clear the virus, they had no measurable immune response to the virus. So we know that if you get a substantial immune response, it'll target the virus and it'll go away. And you should have permanent immunity. What I've seen with patients that I've treated is that when it goes away and they show clear for whatever strain they have, they never have an issue with it again. However, if you end up picking up a different strain that you don't have immunity to, it could be game on again, and you could have a whole problem all over again. The Pap test. A Pap is a way to do a screening of cells on the cervix and vaginal wall to determine whether there's any abnormality. We used to call it a Pap smear because what you do is you would take a spatula like this and say this is the cervix. You would do kind of a scraping of the cervix, and then the cells that were suspended in that sample would be put on a slide and smeared on a slide, hence the term Pap smear. Now we don't use slides anymore. For about maybe about 15, 20 years we've been doing a liquid Paps. So this is a thin prep liquid Pap, and it has certain advantages. One of the advantages is that the Pap's more accurate when you do it in a liquid like this, because you suspend the cells in this liquid and then they go off to the laboratory and a slide is made off of this sample, and it's much more accurate. So the procedure is in effect the same. You use a spatula, take a sample, put it in the liquid, swish it around, and then you'd also take a usually some sort of brush device where you go into the endocervical canal. The endocervical canal, or the opening to the canal, is where most dysplasia occurs. So you can put the brush into the canal. The canal is where, in effect, where a baby comes out. So that canal opens up and allows an infant to be delivered. So you put the brush in, same thing, you put it in the sample, you swish it around, and you're done. So the sample goes off to the lab, much more accurate. What's nice about doing a liquid-based Pap also is that you can do other testing on this. You can do HPV testing, for example. You can do chlamydia, you can do gonorrhea. Most of the time we're doing an HPV test. And most of the time when we do an HPV test, especially here in the United States, we're checking for high-risk HPV strains, not generally the low risk. You can check for both, but most of the time when a doctor says, oh, you have HPV, they're not talking about the low-risk strains, they're talking about the high-risk strains. So you have a Pap done, it's looking at the cells. What does that all mean? The purpose of doing a Pap is to look for abnormal cells. We call these abnormal cells dysplasia. Dysplasia is a precancerous condition of the cervix. The good thing is about 80 to 90% of all dysplasia will never become cancer. Now when you get a Pap done, it's going to be reported in different ways. So the lab is going to actually put together a report with the findings from the Pap itself. They could go one of 4 different ways. So either you're going to have negative for intraepithelial lesion. That just means it's normal, so there's no abnormal cells that are found. ASCUS is an acronym for atypical squamous cells of undetermined significance. All that ASCUS means is that you really don't know what's there. There could be nothing there. It could be from inflammation, it could be from mild dysplasia, or it could be from severe dysplasia. You really have no idea whatsoever. LSIL stands for low-grade squamous intraepithelial lesion. LSIL typically correlates with mild dysplasia, and then HSIL is high-grade squamous intraepithelial lesion, and that most often corresponds with a moderate or severe dysplasia. After having an abnormal pap, it's not unusual for your doctor to want to do a colposcopic procedure. What a colposcopy is simply visualizing the cervix under low-grade magnification, and you can put a vinegar solution or acetic acid on the surface of the cervix, and it causes any abnormal cells to distinguish themselves. So you can, in effect, see them. With the naked eye alone, you can't really see dysplasia. So if you just look at the cervix, you can't really tell what's there. So you put acetic acid on the cervix, you see it, and then the doctor can take a biopsy device and snip off a little piece of tissue off the cervix and send that to the laboratory for analysis. That's called pathology. A pathologist at the laboratory is going to take that tissue, put it under a microscope, and then look at certain features of the cells to determine the level of dysplasia. That's really the whole purpose of doing the biopsy, is to determine, is it mild or is it severe, or is it starting to already look like cancer. So we describe, or the pathologist describes, the level of dysplasia in terms of cervical intraepithelial neoplasia, which is CIN or SIN. So SIN 1 corresponds with mild dysplasia, SIN 2 is moderate, SIN 3 is severe dysplasia, and then finally we get into where it's a localized cancer. That's known as a carcinoma in situ. In situ meaning it's in sight or has not spread yet, and then finally it could be invasive, where it's actually migrating into the deeper tissues of the uterus. Pathology is different than a PAP. A PAP is cytology, or looking at the cell. So a PAP is not quite as accurate as pathology. So when you have a biopsy done, that's considered definitive in that it is more accurate. However, the accuracy is dependent on getting the right tissue. So on occasion, you could have a PAP, you could have a colposcopic procedure, you could have a biopsy, and the biopsy could be wrong. Literally, if you're 2 millimeters off of where the abnormal cells are, you could miss the abnormality and come back and think that everything's okay. That doesn't often happen. I've seen it on occasion, but it's not very typical. So again, these tests are not perfect. A PAP is not perfect, nor is pathology perfect. The advantage of pathology is if it's a good sample, it'll give you a very definitive idea of what's there, whereas a Pap smear may say there's an abnormality there. It could say that it kind of looks mild, or it could say that it looks kind of severe. But without doing the pathology, you don't have a really firm understanding of what actually is there or not. The next concept is critical to understand. Just because you're exposed to HPV doesn't mean that you're going to become infected. And just because you become infected doesn't mean you're going to develop dysplasia. And just because you develop dysplasia doesn't mean you're going to develop cancer. There is a dysplasia continuum. In other words, you go from a normal cell to an infected cell to mildly dysplastic, moderately, until finally severely dysplastic. And in some women, not all women, in some women, it could become malignant. So that's the whole concern. That's the whole reason we do PAPs, is to attempt to identify dysplasia early on in the continuum while we can still do more about it. So what does a healthy cervix look like? This slide demonstrates an extremely healthy looking cervix. It's pink, it's clear, there's no lesions on it. This is quintessential healthy cervix in the upper left. The middle upper is showing leap damage. This is a woman that had a leap a couple years before coming to see me, and it resulted in some scarring that you can see. The slide on the upper right with the question mark is her after I treated her. Unfortunately for her, the dysplasia came back after the leap. She never cleared the virus. She never cleared the HPV. The dysplasia came back. I treated her with an escharotic solution, and the slide with the question mark is her after treatment. So the dysplasia cleared, HPV went negative, and the scarring around the opening of the canal went away. The lower left is showing conization damage. It's a more aggressive procedure, as I've stated, and it can result in deformity of the cervix at times. The middle lower is showing endocervical stenosis. Sometimes when you have a LEEP or conization done, it will heal and it will close up the canal. So her canal is obliterated. She no longer has an endocervical canal. There's no opening to the uterus, which obviously presents some problems. And then the post-LEEP adhesions, this is a woman that had a LEEP done, developed an infection, and then had excessive scarring with the tissue adhering to the vaginal wall. It just was a complete mess. The main point of this slide, however, is to just demonstrate what a healthy cervix looks like. Now you contrast that to this. This is what dysplasia looks like after applying a staining solution. This solution happens to be an escharotic solution, and similar to acetic acid, it ends up allowing abnormal cells to be visible, but unlike acetic acid, an escharotic solution will end up killing these abnormal cells. I talk about that mechanism of how that actually works in my book. But you can see this is actually a pretty large lesion. It happens to be a CIN2 or moderate dysplasia. The hallmark of dysplasia are these, if you look at really closely, the surface kind of looks like the surface of the tongue. It has these little papillae or these little projections that make it kind of rough. That's very characteristic of dysplasia. Here are two cases of very severe CIN3 or very severe dysplasia demonstrating surface deformity that you see with severely dysplastic lesions. The woman whose image is on the upper right, I ended up treating with an escharotic solution, and you can see here after doing 12 treatments, her image is on the upper right, the dysplasia cleared and she went HPV negative, and she contacted me about 5 or 6 years after this image was taken, and she was still HPV negative and the dysplasia had never come back. Okay, hopefully now we have a better understanding of what HPV is, the difference between an HPV test, a Pap test, the difference between a Pap test and biopsy or cervical pathology. Hopefully this is helpful and you'll be able to make a better determination about what to do. Okay, what is your doctor going to tell you to do? If you've just got a recent HPV infection and your Pap is normal, your doctor's not going to do anything. Your doctor's going to say, don't worry about it, the HPV will go away, you don't have to do anything. And if you even ask and say, well, is there anything that I can do about it? Your doctor's going to tell you, no, you don't need to do anything, it'll go away by itself. And maybe it will. If it doesn't go away, however, say a year later you do another Pap and HPV test comes back positive again. Now this time the Pap comes back abnormal, maybe a low-grade lesion like an L-sil. Your doctor's, or an ascus, like atypical squamous cells, your doctor's going to say, we need to do a colposcopic procedure and biopsy. So you have the biopsy done, and then the biopsy comes back, say CIN1, which is mild dysplasia. Your doctor's going to say, we don't need to do anything, we'll just watch it, we'll do another Pap 6 months from now or a year from now, and we'll kind of go from there. And again, if you ask, is there anything that I can do about it? Your doctor's going to say, no, there's nothing you need to do about it. Which is not true. And in future videos, I'll discuss in more detail about what to do under different circumstances and some of the evidence-based, research-based things that you can do to help clear HPV and help prevent HPV from causing dysplasia. Okay, so you have mild dysplasia, your doctor's going to say, don't worry about it, you don't have to do anything. And then you come back in another 6 months or a year, you go through the whole procedure again, it's HPV positive, the Pap is saying there's an L-sil there, or maybe this time now it's looking more higher grade, like it comes back a high grade lesion, an H-sil. You're going to have another biopsy done, and if the biopsy comes back either with CIN2 moderate dysplasia or CIN3 severe dysplasia, your doctor is going to insist upon doing an excisional procedure. In other words, your doctor is going to want to excise or cut out some part of your cervix. That's usually going to be in the form of either a LEEP, which is a loop electro-excisional procedure. It's a cautery instrument that can cut out part of the tissue, or you'll have a conization or a cold knife conization, which is a more aggressive surgical procedure where you can remove a larger portion of the cervix. Cold knife conization is probably most often done in cases where there's canal involvement, or maybe where you've had previous leaps and now the doctor's starting to get a little bit concerned that there's maybe something more there. So when in doubt, they'll take more. Now, the reason your doctor does this isn't because he or she hates you. Your doctor is following treatment guidelines, specifically ACOG guidelines, American Council of Obstetricians and Gynecologists. So like many areas of medicine, there's diagnostic guidelines, there's treatment guidelines. In this case, there's very detailed guidelines on what to do under what circumstances. So your doctor is actually just simply following these guidelines that say what to do. Now, they're not necessarily good guidelines, or at least they're not always good guidelines. But what's nice about guidelines is that they attempt to be evidence-based. And the nice thing about guidelines is then there's consistency in the practice of medicine, and you can make comparisons, and that in itself can be useful. The downside of guidelines is that it really threatens to eliminate alternative ways of treating things, and that can be damaging. For example, if you have HPV and maybe mild dysplasia, and you ask your doctor specifically, because your doctor's going to say, don't worry about it, we'll recheck it in 6 months or a year. But if you've done research, and you come back to your doctor and say, well, what about folic acid? Okay, because we've known since 1966 that folic acid deficiency can contribute to cervical cancer. This is really an established fact. There's tons of studies now and correlations. It's even been shown that when you have higher levels of folic acid, it may be able to help prevent an HPV infection in the first place. So you go to your doctor and you say, what about folic acid? Then your doctor will know that you know something about it, because your doctor knows about folic acid. All of them do. Everybody knows that folic acid is important with cervical dysplasia, but your doctor doesn't say anything about it because they're not part of the treatment guidelines. Folic acid is not part of the treatment guidelines. There's nothing about nutrition or diet that's part of the ACOG treatment guidelines, despite there being evidence to the contrary, which I cover all of this in my book. For example, diet alone. When you eat a plant-based diet, the research has shown that you get a 50 to 60% improved likelihood of clearing HPV. 50 to 60% improved likelihood of clearing HPV is substantial. So there are other things that you can do regarding HPV and cervical dysplasia. I'll be talking more about that in future videos. If you found this video helpful, please click like, and please share the video. And also, if you want future videos where I talk more about treatment, everything and anything that's HPV related, subscribe to my channel.